Hi everybody, welcome to part 2 of the evaluation of the IVC. We left off last time making the point about primary tumors of the IVC are rare, but we do see them, and if you've seen a couple you could recognize them. They can be very confusing. They can look like retroperitoneal sarcomas that secondarily involve the IVC. You might wonder, could it be a renal cell involving the IVC? But it's particularly impressive tumors. Again, they are large. They don't always have neovascularity. Sometimes they're large and relatively hypovascular. If you look at data from large records, 37% of tumors occur in segment 1, below the level of the renal veins and above the iliac vein bifurcation. 43% involve segment 2, between the renal veins and the level of the hepatic veins, and 20% from segment 3 at or above the hepatic veins and may lead into the patient's right atrium. Most of the ones that I've seen in our practice tend to be for an extended distance, usually beginning above the IVC bifurcation into the iliac veins. Some facts: female over male 4-to-1, average age 54. Surgery is the key therapy, with radiation therapy and chemotherapy unproven in terms of value, and most of these are going to be leiomyosarcomas. When we talk about things that give IVC thrombus, we mentioned tumor extension. Adrenal, renal, hepatoma are the most common ones we think about. Lung cancer also, but that's usually SVC involvement and extension from above downward. And then, of course, there's IVC sarcoma. As we mentioned, the different locations of IVC sarcoma, most commonly, as I mentioned, segment 1 is the area I'm going to see most of the tumors. Here's a nice example. When you look at this case, you can see it's compressing the portal vein. It's abutting the patient's hepatic artery near the celiac axis, but it's hard to tell. This could be an adrenal carcinoma. That's definitely a possibility. You'll want to see the upper and lower stents, but this was a primary tumor of the IVC. Here's another case, a large mass. Again, is it something involving the IVC secondarily? You can see it tracks way upward into the IVC, up to the level of the right atrium. You could be thinking about the usual tumors: hepatoma, renal cell, adrenal. And of course, I would be very careful in this case that I'm not overlooking a tumor. Sometimes adrenal can be particularly tricky. If you see nothing, then it's a primary IVC process. It's expanding the IVC. There's neovascularity present. This was a primary leiomyosarcoma. Another example here, very similar to the prior case. You can see the tumors growing upward. You see the neovascularity literally coming into the base of the heart. Here it is again, a few more images. Impressive neovascularity. I've excluded, after looking carefully, other possible sources like renal and adrenal and liver. This was a primary adrenal IVC sarcoma. Very, very nice case. Very, very nice example. Here's another case. This was a leiomyosarcoma, IVC primary. Again, large retroperitoneal appearing mass. You don't really see the IVC. Is the IVC compressed? Is it invaded? Or is this arising from the IVC? It has dystrophic calcifications. At the end of the day, at surgery, this was proven to arise from the IVC. Impressive neovascularity, impressive calcifications, just a very large tumor, and a little bit atypical in that it's sitting so far central. Here it is with the cinematic rendering. The necrosis, the lack of IVC visualization should make you really think about that possibility. Very unusual, very aggressive tumor, really nice example. Here's the sagittal views showing you that as well in this case. So a very impressive case, very nicely defined. Another example here looks similar to the prior case, right? Large mass. Could it be a retroperitoneal sarcoma, like a fibrosarcoma, leiomyosarcoma? It's not going to be a liposarcoma. There's no fat. But then you see neovascularity, you see dystrophic calcifications. You're not really visualizing the IVC. When you look real carefully at all of the images, you realize this process, when you go through the differential, probably is arising from the IVC. And this was an IVC sarcoma, very nicely shown on the patient's coronal views, and on the MIP imaging with the neovascularity is particularly impressive. Here's a few more images showing you that as well. And here again, some volume rendering and some MIP imaging. I think IVC sarcomas at times, to me, when I show them in conference, unless you've seen them before, you never really think of that possibility. But when you look at the epicenter, you look at where is the IVC, then I think you can suggest the correct diagnosis. And here are the images as it washes out on venous phase imaging. You can see the extension up the IVC on these examples here. And again, the epicenter is here. Again, you would think about all the possibilities, but a very, very unusual tumor. And here it is again with some cinematic views. Very, very nicely defined. So a really unusual diagnosis, IVC sarcoma, almost always leiomyosarcomas, but something to think about. And again, go over this lecture, look at the images specifically. Once you've seen a few cases, you'll recognize it. But again, we're seeing a case every year or so. It's uncommon. One of the things with the IVC, Budd-Chiari syndrome results from obstruction of the hepatic vein outflow tract, usually at the hepatic vein levels, and most commonly is associated with hypercoagulability states. Obstruction of the hepatic portion of the IVC, either by web, stenosis, or clot or tumor invasion, is a rare cause of Budd-Chiari syndrome, but it can occur. More frequently, the IVC is narrowed and compressed by a markedly enlarged caudate lobe. The CT appearance of Budd-Chiari is well recognized. In the acute phase, there's preferential enhancement of the hypertrophied caudate lobe in the arterial phase, followed by heterogeneous enhancement of the liver with peripheral linear low attenuation bands and areas of infarction in the portal venous phase. In chronic Budd-Chiari syndrome, there's patchy hepatic enhancement, best depicted in the portal venous phase. Low attenuation thrombus may be visible in the hepatic veins and IVC. In addition, the enlarged and tortuous collateral veins from the azygos, hemiazygos, and lumbar venous system can be seen bypassing the occluded IVC. So again, most of the time with Budd-Chiari syndrome, you're going to recognize Budd-Chiari syndrome and see a compressed IVC intrahepatic. In other cases, the IVC will be occluded, but that's going to be less common. And as I mentioned, acute Budd-Chiari and chronic Budd-Chiari. Again, early enhancement of caudate lobe and central portion of the liver around the IVC with decreased enhancement of the rest of the liver. So central brightness, decreased enhancement distally, narrow hypodense hepatic veins and IVC with dense walls can be seen. And in the chronic phase, non-visualization of the IVC and hepatic veins with presence of regenerating nodules, a common appearance. Now, I won't go into management of Budd-Chiari, medical management, usually with anticoagulant therapy. Other cases need surgical management, including liver transplant, endovascular therapy, including angioplasty, stent placement, and catheter-directed thrombolysis also can be done. Here's a nice example of Budd-Chiari in a patient with coagulopathy. The hepatic and infrahepatic IVC is not visualized. You can see the prominent periaortic venous collaterals, very nicely shown in this case. Here's another example, a very compressed but patent IVC, prominent caudate lobe. This is arterial phase. The caudate lobe is brighter than the rest of the liver. Here we go more toward the venous phase. Now you see peripheral enhancement, flat IVC, but the IVC is not occluded. And here's just a few more images showing you the flattened IVC, the patchy enhancement in the liver. Another example here with a very flat, barely visible IVC, patchy enhancement of the liver, And as you go onward, there are regenerating nodules. Portions of the IVC intrahepatic do appear to be occluded, but we do see a slit of the IVC as we look more carefully. But this is one of those cases where there is IVC occlusion as well, and you can see the regenerating nodules present. Sometimes the challenge, of course, is regenerating nodules versus hepatoma. But when you see Budd-Chiari, you got to be thinking you're dealing with regenerating nodules. And you can see on the image on your right, the IVC, the extrahepatic IVC, is clearly patent. And here's just the coronal views in that case, showing you the lack of good visualization of the intrahepatic IVC, which was occluded. And again, the MIPS very nicely showing you the too numerous to count regenerating nodules. Now, IVC stents and filters, very common to see IVC stents in place. We look very carefully at stents to make sure there's no thrombus still present. Again, coronal views are very, very helpful in that regard. CT can accurately display the location of filters, their relationship to renal veins, and potential complications such as migration and embedding in the wall of the IVC. In cases where filters need to be removed, CT is a good guide. Here's just a couple examples of IVC filters in place. Image on the left showing a thrombus beneath the IVC filter. Image on the far right showing a patient with a history of IVC migration of the filter, and you can see the filter, several things. It's very close to the level of the renal veins, and one of the prongs appears to be embedded in the medial wall of the IVC. All important findings. So look carefully. IVC filters are used very commonly, and complications do occur. Now, some miscellaneous things I'll just mention. Retrograde opacification of the IVC. This is most common in patients with poor right-sided heart failure. You see reflux of contrast, particularly with a good injection into the IVC as well as the hepatic veins. That's the most common presentation. In passive hepatic congestion, the liver is congested due to cardiac disease. Again, it's usually poor right-sided heart function, but also can be due to congestive failure, constrictive pericarditis, tricuspid insufficiency, or just right-sided heart failure. Cardiac cirrhosis may be irreversible, even if cardiac function does improve. The things we look at, again, retrograde flow into the IVC and hepatic veins, a mild enhancement of the liver, a large liver, ascites, and periportal edema. Here's just a nice example, really impressive reflux into the IVC and hepatic veins. Again, this is arterial phase, and that's typically we really appreciate the reflux of contrast. Here it is with MIP imaging, and here it is with volume rendering, all in the same case. And here it is from above and below with volume rendering and MIP imaging. Really impressive how extensive that reflux is into the IVC and into the hepatic veins. And again, typically I see this in patients with poor right-sided heart function. If I don't scan the chest and I'm only scanning the abdomen and I see this, I'll suggest that the patient has right-sided heart failure, even though I'm not seeing the heart. Some miscellaneous conditions, IVC fistula. Typically, it's between the IVC and adjacent organs, usually when there's a tumor present. I've seen it as a result of a IVC filter perforating. Communication between an aortic aneurysm and IVC is easily diagnosed by demonstrating the early enhancement of the IVC in the arterial phase. But again, it's fairly uncommon, but it does occur. I'll also mention the flat IVC. That typically is a finding in patients who are hypotensive. We think about bright adrenal glands, bright blush and bowel, as in the case you see here, and a very flat, almost invisible IVC. A flattened IVC is defined as a transverse to AP diameter ratio of 3:1 or more, seen at multiple levels. And again, it was initially described, I think, Brooke Jeffrey, in shock patients. It's not just in trauma patients, but in any patient who's hypotensive, we can see this. Occasionally, a flat IVC can be a normal variant, particularly in older women, but that's uncommon, and you better make certain the patient isn't hypotensive. Here's a nice example of very bright, hypotensive patient, flat IVC, bright adrenal glands. Here it is on the axial again, the flat IVC, and look how flat the IVC looks when you look at the patient's sagittal views. Just a very, very nice example. Again, you don't need that sagittal view. Typically, the diagnosis is made on the axial views. So conclusions, I've gone through a number of pathologic conditions affecting the IVC, nicely shown with CT. Again, I mentioned if you're uncertain at times, MRI can be helpful. Occasionally, ultrasound can be helpful. However, in the scheme of things, CT usually allows you to make the right diagnosis. Think about the different pathologies with IVC involvement, from tumors to inflammatory disease. Some of the secondary signs in the IVC, whether it's a flat IVC suggesting hypotension. Think about the cases where IVC has been treated, like with a stent, looking for complications. When you think of all of that, I think you'll do a great job. And with that, have a great day. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.